just going to be talking about biopsies rather than resection specimens, but it is important to know the basic anatomy and the sort of different parts of the stomach when you're reporting gastric pathology. Chemical and iatrogenic injury, important topic, given that I do every now and then see certainly dysplasias and suspicious reports from obviously benign injury, mucosal injury. And then moving on to sort of classic inflammatory gastritis of the different types, and then non-neoplastic mimics, for example, of malignancy. Polyps, and moving on to what I would call true gastric type dysplasia, rather than the sort of adenomas that you're used to seeing in the colon, which should be second nature reporting at quite an early stage in your training. Neuroendocrine lesions, which are slightly different in the stomach compared with other sites, and then carcinoma of various types, including what I'm calling the sneaky and unexpected imposters. So I'm intentionally avoiding covering sort of mesenchymal tumours and sarcomas. They do crop up in the stomach. I've got many examples of these kind of things, but I'm not planning to cover them because I've recently done a talk on GIST and their mimics. I think I've got a list of about 25 or 30 other types of lesions that radiologists and clinicians have confidently called GIST, which have turned out to be other things. So, why am I interested in gastric pathology, and why do I deserve to be talking to you about it? Well, for about 10 years or so, I was the regional pathology lead for the Pathology Esophagogastric Cancer Centre when it was regionalised in 2010. I joined just after that. And it gave me the opportunity really just to see lots and lots of pathology, both biopsies and resection specimens. And that was just an audit I did. That pie chart, showing that certainly most of the pathology is actually from the esophagus and esophagogastric junction, and nearly all of them are adenocarcinomas, in contrast to the what the early books would say, 50-50 adenocarcinoma and squame. I think the last time I checked it was at least 80% adenocarcinomas in the esophagus, for example. And in the stomach, adenocarcinoma is even more frequent than it is in the esophagus. And really the difficult cases, as it is in a lot of the kind of pathology we report, are the sort of dysplasias, the sort of suspicious biopsies, the pre-malignant ones, and the sort of mimics, mesenchymal lymphomas and things like that. So we'll touch on those things. And in terms of the anatomy, we know that there's this short area of the term the cardia in at the esophagogastric junction, and then the body and the fundus, which histologically look quite similar, and then the antrum and the pylorus, and then this sort of little notch here, which isn't very well demonstrated, called the incisura. So I'm not going to be talking about the esophagus or the duodenum, just the stomach. So this was from a sleeve gastrectomy which I received a few days ago, so I photographed it after having recently lost all of my digital slides, which I'd prepared for this talk. So all we've got today is snapshots like this. So the normal gastric body, we're not really going to be talking about anything outside the mucosa and submucosa, because on biopsies it's all you tend to get is the mucosa and the submucosa. But I put this in just to demonstrate that in the gastric body, you'd be looking for very short foveolar pits. So they look a little bit like colonic crypts, but they're much shorter, and they're lined by this mucinous epithelium with basally located nuclei, columnar-shaped cells, and no goblet cells. And as you can see, there's very little lamina propria at all in the normal stomach. This is a little bit congested, but otherwise you shouldn't be seeing many inflammatory cells separating the foveolar pits. And in the gastric body, it's a pattern of short pits and long glands, and the glands are made up of parietal cells, which are the ones with the granular eosinophilic cytoplasm, and the chief cells. and we'll move on to talking about those when we talk about different types of gastritis. The antrum, in contrast, the distal part of the stomach, and the pylorus looks the same under the microscope as well, is made up of long pits and very short glands. So these are the glands, and they're called pyloric glands. So even in the antrum, they're called pyloric glands, so they produce mucin. And you'll see these kind of glands all over the GI tract. But when they're not in the pylorus or the antrum, they're called pseudopyloric metaplasia. And they're found whenever you see any kind of ulceration or erosion and regenerative changes, you see proliferation of glands that look very like they do in the antrum and pylorus, but they're metaplastic in origin. And I think you can just see here that in the base, or just above the pyloric glands, you've got these sort of fried egg shaped cells. And I'm sure some of you will know what those are. Some people do immunohistochemistry to identify them, but after a while you won't need it. And these are the antral G cells. Okay, so these are neuroendocrine type cells, and they produce gastrin. So this is more of the kind of biopsy that you get from, I would say it's probably the most common gastric biopsy you get. And it's from the antrum, and it's almost normal. But you can see that the foveolar pits are particularly long, and you can see that some of them are starting to become tortuous or corkscrew shaped. And this is termed gastropathy, so it's not gastritis. In fact, if you look between the pits and in the lamina propria, there's sometimes even less inflammatory cells than you get in normal mucosa. So there's a paucity of inflammatory cells. One of the things you'll just about see are there's some thin strands of smooth muscle that are coming up to support these elongated pits and regenerative glands. And you can see that they're starting to become a little bit tortuous, these pyloric glands as well. So this is antral gastropathy. I'd say on a pretty regular basis, I get someone bringing me a biopsy of antral gastropathy saying, is this dysplastic? And this isn't a particularly good example. I had some better examples which I unfortunately lost on my hard drive recently. But you can start to see that the nuclei can look a little bit hyperchromatic. But this is all just reactive change. In fact, there's probably an erosion here. You know, you've got loss of the surface epithelium here. So remember, an ulcer is when you lose the mucosa completely and the surface is replaced by inflammatory slough and neutrophils, whereas with an erosion, you're just losing the surface epithelium. And sometimes our clinical colleagues will call something a small ulcer when they actually mean an erosion. But you can see that, you know, if you're worried about pits like this, actually the important thing is not to look at these at high power in isolation. It's to look at the entire area at lower power, and you can see that, you know, this is all right, this area is okay, getting slightly worse, getting slightly worse. There's a gradation of reactive atypia here. And I tend to actually not use the word atypia in my reports at all. I just call it reactive changes, because otherwise you tend to get emails saying, oh, this is atypical, does that mean it's dysplastic? You can see here that, a little bit like in Barrett's epithelium, the normal foveolar epithelium retains a little cap of mucin here, and there's a beautiful little line there separating that mucin cap, which would be PAS positive rather than alcium blue positive from the epithelium lower down, and that tends to be retained in this reactive looking epithelium as well. Okay, and those tortuous pits can get really long and really tortuous, and in fact, as we'll move on to talk about, this kind of appearance on a little biopsy may be representative of a hyperplastic polyp, which is effectively the same as reactive gastropathy but just exaggerated. And this is just a slightly higher power view of this more smooth muscle strands in reactive gastropathy with these tortuous pits. So this is the kind of thing that you see every now and then, and again I got this biopsy just a few days ago, which was a patient, in fact someone asked me if this was a medication injury, but in fact this is just bile, crystalline bile, which is deposited on the surface of an area of reactive gastropathy, and you could see it on the endoscopic pictures. Effectively, it looks like gallstone fragments. This is something which I encountered a fair bit when I was doing my regional job, and you can understand, you get these nasty, really indurated looking ulcers. It's a true ulcer with this black centre here, and heaped up mucosa around the side, quite red. From a clinical appearance, this really looks like a cancer, but it's typically on the posterior wall of the stomach, and often in an elderly, frail patient who might be stuck on a medical outlying ward, and a physician will come in and present the patient saying, I think this patient's got cancer. But on the biopsy, you get this crystalline sort of brown to black material, which is indicative of iron pill gastropathy, and that causes a caustic destruction of the superficial epithelial cells in the gastric mucosa. And at higher power you can see this crystalline material here, and what's this stain here? It's a Pearl's Prussian blue stain, which you can do if you're not confident of looking for iron debris. It certainly helps confirm the diagnosis of iron pill gastropathy, and also save the patient from unnecessary CT scans and things like that. It's always important in gastric biopsy pathology to just stay cautious and to stay, to be not quite so dogmatic sometimes. If you've got a decent biopsy and it shows iron pill gastropathy, that's fine. But, if you've got a suspicious biopsy, and let's say someone has got a CT scan that does look like cancer, and you've got a bit of iron pill on the surface, don't jump out there and say this is iron pill gastropathy only, because there may be a cancer there as well, and the patient just happens to be on iron, which a lot of anemic patients with cancer are. So this is what I mentioned before. This is what I tend to say. I don't just call these hyperplastic polyps, because they're not neoplastic. These are hyperplastic regenerative type polyps. They're nearly always in the antrum of the stomach, and this is the appearance on the endoscopic pictures. The mucosa always looks abnormal around it, often with ulceration elsewhere as well. And then, a polyp of more than 2 centimeters anywhere in the gastric mucosa is malignant until proven otherwise. And so this is one which was removed and shows the typical exaggerated foveolar hyperplasia and tortuous pits, as well as a sort of villiform surface of a hyperplastic regenerative polyp. It is worth obviously looking at every single section of these and embedding them in toto, because they do develop dysplasia like anywhere in the injured chronic inflamed gastric mucosa. They can develop dysplasia, and it's usually a foveolar type, which we'll move on to describing. They can have intestinal metaplasia as well, but they usually are in the antrum, just with long foveolar tortuous pits. This is the another common polyp that we see in the stomach, which is a fundic gland polyp. And you can see that here, this is in the fundus of the body, because you've got short pits and long glands. And then you've got this beautiful sort of sessile, slightly pedunculated polyp that's filled with multiple cysts. And the cysts are in the actinic glands themselves. So they'll be lined by parietal and chief cells. Sometimes they have a partly foveolar lining as well. And these are nearly always sporadic in patients that are on proton pump inhibitors. In fact, you can see down here in the mucosa surrounding the polyp that there's other dilated glands, and if you look closely, there'll probably be some other changes that are classical of PPI use, sort of omeprazole, lansoprazole. This was an area that a colleague of mine asked me to look at, was concerned about dysplasia. Same principles that I was talking to you about before. I didn't think this was convincing dysplasia because there was no abrupt transition. You can see this is just gradually turning into slightly more hyperchromatic, and actually you can still see that surface mucin vacuole there just retained at the top. And then these are at higher power, these are the actinic glands showing what I call PPI related changes. You can see this almost like apocrine blebbing of the cytoplasm into the lumen here, and a few macrophages here. and sometimes this epithelium of the parietal cells becomes quite vacuolated as well, and that's another sign that the patient's on PPI. I've actually diagnosed one of these and written up which occurred in the rectum within a patch of gastric heterotopia. So they happen everywhere. So this, in contrast, this is a fundic gland polyp with obvious dysplasia. You can see that there's quite an abrupt transition here, even at this very low power, between the normal surface and this quite sort of villiform dysplastic area. And this is a higher power view of this area of dysplastic epithelium, and it's a foveolar type. It doesn't matter much what kind of dysplasia you're diagnosing in these. One of the things that I always do is check the history, because if you have an elderly patient, with an odd fundic gland polyp which shows dysplasia like this, then it's probably sporadic. And a patient with long-term PPIs that's got multiple fundic gland polyps. But I'm sure anyone pop on the chat what kind of syndromes you can get dysplastic fundic gland polyps in. The main one is FAP. There is another one as well. So there's a syndrome called GAPS, gastric adenocarcinoma and polyposis syndrome, which is basically the same as FAP. It's just a different part of the APC gene, which is mutated in the germline sense in patients that develop GAPS, and they tend to develop more gastric rather than colorectal adenomas. So this is a higher power view of this foveolar dysplasia. You can see it's quite subtle. If you saw this on its own, it would actually be, without the context of that abrupt transition between the normal polyp and abnormal. I find we'll go on to talk about foveolar dysplasia, but it's a real pig to try and diagnose, because you've still got this apical mucin vacuole, and actually it's only when you see it changing from normal to abnormal when you can really tell that it's dysplastic. So this is an exaggerated example of the kind of artifacts that you can get in oxyntic mucosa. So this is clear cell change in gastric parietal cells, and this was in the context of a fundic gland polyp. And someone brought me this and said, I'm a bit worried it's signet ring cell carcinoma, and obviously it's not. You can see that these glands are very well defined. Signet ring cells don't form cohesive clusters like this, with this ordered sort of pattern. They're discohesive by their very nature. And this is but you can see if you start looking really closely at high power at these cells, you could probably convince yourself that they're malignant. But these are artifactual signet ring-like cells, and actually there were areas of the polyp where you could see sort of normal parietal cells merging into the abnormal cells. And this is something which Ranjan Chetty and other colleagues have published, gastric parietal cell vacuolation mimicking gastric cancer. Weirdly, in this particular patient, I went back and I thought, well, I'll look at a fundic gland polyp that he's had before, because he's bound to have had other ones. And I pulled one out of file from about 5 years before, and it had exactly the same appearance. Tiny little polyp in his stomach, which showed this parietal cell vacuolation. So I don't know if anyone knows what these things are here. So these cells, again, can sometimes cause problems and make people a bit anxious. So these are called gastric mucous neck cells. They're pretty difficult to see in normal mucosa. I do find that you see them more when there's been some sort of injury to the gastric mucosa, or that it's just a funny tangential section and they just tend to stand out. But you can see that these are all in the same little band of mucosa, in the band of epithelium, and they don't stain, or they don't lose E. cadherin, and they certainly don't infiltrate the lamina propria. They're benign and reactive phenomena. And then this is something which crops up every now and then. So usually a yellow patch in the mucosa, which will be visible endoscopically, but not always. You could I've seen these from time to time in areas where there's been an ulcer, and the or some H. pylori related damage. And I think probably what happens is the cell membranes just become, mopped up by macrophages, and it forms a xanthoma. They're not always related to hypercholesterolemia or any sort of systemic conditions. So these are other signet ring cell mimics. Just looking at the time to make sure we're doing all right. So this is another one which, again, I saw this quite recently, and someone sent me some pictures. Does anyone know what this is called, this condition? This is a biopsy from the gastric mucosa of an area which the endoscopist thought looked inflamed. I'm going to keep looking at the chat just in case there's any messages pop up. Great, I can see some good messages here. These are actually Russell bodies, so they're congested plasma cells. So this bright red material, which is immunoglobulins within these abnormal plasma cells, starts to compress the nucleus and form this kind of almost, lipoblast-like or signet ring cell-like appearance. If you were particularly excited by this, you could do something like a kappa lambda ISH stain, which would show that they're polyclonal. Nearly always related to previous H. pylori. So it's just, that they've got long-term, sometimes untreated H. pylori gastritis, and that the plasma cells have carried on pumping out immunoglobulin and form these funny cells. And this is one from a colleague up country who just showed me this beautiful picture of signet ring cell carcinoma and how much Russell body gastritis can look like it. This is something which I've got probably enough for a good case series of this now. Nearly always in the proximal stomach. If you like looking at endoscopy pictures like me, you can see this is a squamous epithelium of the esophagus here, and this is a bit of Barrett's mucosa here, and then this is a bit of hiatus hernia pushing up into the esophagus. But these things are nearly always right at the GOJ, tiny little polyps, and they show this bizarre stromal reaction in the ulcer bed. Often I find have a lot of eosinophils and other granulocytes dotted around, and the cells, if you start getting used to these almost smudgy kind of purple blue cytoplasm that comes off these reactive myofibroblasts, these are completely just little inflammatory polyps that for some reason have bizarre stromal cells within them. But nonetheless, you wouldn't be doing your job properly if you didn't do some immunohistochemistry just to make sure that it's negative for cytokeratins and CD45 and S100 and low key 67. And I've also done from time to time a cytomegalovirus or HSV immunohistochemistry just to make sure they're not viral related changes. So this is in the textbooks or some textbooks. I think this is one of Liz Montgomery's books, showing bizarre stromal reaction in ulcer bed. And as I say, I've nearly always seen these at the GOJ in these tiny little, sometimes 2 or 3 millimeter polyps. So having that clinical context and looking it up yourself and just making sure it's obviously not some big fungating mass, with a mediastinal component is reassuring. But these you will see from time to time. You even see them sometimes in the colorectum as well. So this is a very recent case. Just a sleeve gastrectomy I had from a, believe it or not, a 22-year-old female, obviously from the private sector, who, at very low power, it's a nice normal stomach, like they nearly always are, but perhaps an increased density of lymphoid follicles here in the basal mucosa, and quite a dark line of inflammation pushing these parietal cells down in the gastric body. So this, even at this times 0.4 times appearance, you can see this is a superficial chronic gastritis. And in old language, this equates to being H. pylori gastritis. You can see there are, between the foveolar pits, increased plasma cells, increased lymphocytes, and also between the parietal and chief cells as well. And I did the immunohistochemistry just because it was a private one. Why not waste a bit more money? And also for some good control material. On digital slides, as you probably know, it's quite difficult to see organisms, and so I have a low threshold when the pattern is right to do immunohistochemistry, which I like better. But in fact, even at 20x magnification on the digital slide, I could see the organisms, so I was being a bit naughty doing the immunohistochemical stain for teaching purposes. So when to test? Well, it's exactly that. I've already told you, really. I was told as a trainee that if you see superficial chronic gastritis and find the area with the granulocytes in the epithelium, then you'll find the organisms, and generally that is true. That previous case of the young woman, it was very hard to see neutrophils, so it was purely the superficial chronic gastritis pattern that led me to believe that there was Helicobacter there, which was confirmed. If you don't see it, you don't see it. I don't stress about it too much. And I certainly don't do Helicobacter immunohistochemistry on things like fundic gland polyps and reactive gastropathy and things like that. But I do listen to my clinical colleagues. If they say, I want to know if there's a Helicobacter here and it looks inflamed, then I'll do it. But I don't do it on things like polyps and non-inflamed mucosa. It's just a waste of money and time. And if you're lucky, you not only get the positive IHC, but you also can see the morphology of the bacteria as well. So moving on to slightly more uncommon inflammatory patterns. This is actually a consultant physician colleague of mine, which always makes you worry when you get a biopsy from a colleague. So she was known to have celiac disease, but also had some upper GI symptoms. And so they biopsied it, and this is antral mucosa, and there's a brisk increase in intraepithelial lymphocytes. So this is lymphocytic gastritis, and it's important to remember that lymphocytic gastritis is a histological pattern, it's not a diagnosis. So you still ideally want to find the cause of this. This was reported by an outsourcing company as lymphocytic gastritis, probably related to celiac disease because it had included that history. But I did immunohistochemistry and actually found that she also had Helicobacter gastritis, so she could have eradication. It probably didn't sort out her lymphocytic inflammation and her autoimmunity, but seemed to improve symptoms having Helicobacter eradication. So I would say have a low threshold to test, even in unusual patterns of gastritis. Helicobacter causes almost all of them. I like endoscopic pictures, and this is one that my friend Sean Walsh gave me last week. Varioliform gastritis. So varioliform means pox-like, but we thought they looked quite a lot like octopus suckers. And in the idiopathic form of lymphocytic gastritis, then this is a sort of classic endoscopic pattern. You need to find more than 25 per 100 epithelial cells, and as you probably know, they're usually CD8 positive T cells. There's a variable inflammatory expansion of the lamina propria, tends to be more antral predominant. That antral predominant pattern is more common in celiac patients. But if they don't have known celiac disease, I would still recommend, especially if you don't find Helicobacter, to do a TTG, or for your clinical colleagues to do a TTG to make sure that they don't have celiac disease. Helicobacter testing is always recommended, but there are multiple etiologies, medications and Crohn's disease, etc. So all they do is they target the cause in order to treat this. So this is collagenous gastritis, so a little bit like in the colon, you've got lymphocytic and collagenous. This is a little bit different. Again, it can be related to Helicobacter. It's got a female predominance, so again, possible autoimmune component. There's this artifactual sort of cleft. Often this, I think, looks quite sort of like a hard sort of almost stiff appearance to this collagen, and you get cracks in it, and sometimes, you know, this lifting off of the surface epithelium is quite characteristic. You can also get sort of capillaries appearing in this collagen as well, as it tries to repair the surface epithelium. Often you don't have much of an increase in intraepithelial lymphocytes, so it's not like so much like collagenous colitis in the collagenous colitis. Sometimes the inflammatory component can be quite mild, and you can use a Masson's trichome. You should be about more than 10 microns thick, so at least more than 2 lymphocytes thick, because you don't want to overdiagnose on a cross-cut section. But this is a better high-power one with a corresponding Van Giesen stain, and again the endoscopic appearance is fairly classical, sort of cobblestone or nodular appearance. Also, like as I've mentioned, you know, it can coexist with other pathologies, so once you've diagnosed this, if you ever do, don't forget to look for other things like intestinal metaplasia and dysplasia. So this is, I've just got, again, this is from my friend Sean Walsh. These are 2 cases which he received with slightly different endoscopic patterns. This is an older chap with a mild gastritis. You can see there's a little bit of exudate here in the stomach and looks a bit red. And then this was a younger chap with sort of these little erosions, but not much gastritis. And we had gastric antral biopsies. So in the older chap, non-necrotizing granulomas and quite a bit of inflammation around, including active gastritis. And in the younger man, there were non-necrotizing granulomas, but no necrosis and minimal inflammation, no active gastritis. So this chap had a previous colectomy for Crohn's, and so almost certainly was a Crohn's gastritis. And this chap had known systemic sarcoidosis. So granulomatous gastritis, uncommon, but you've always got to do a systemic search for an underlying cause. Crohn's, sarcoidosis, infections. If you've got necrotizing inflammation, of course, you need to think about mycobacterial or fungal infections. And don't forget Helicobacter. It can still be a cause. Another case that I've had recently with granulomas, interestingly, had dysplasia and a carcinoma in one of the biopsies. So presumably, some of these patients can also have granulomas as a sort of paraneoplastic phenomenon. So don't let one diagnosis distract you from other possible ones that might be more serious. This is something that I just wanted to really try and hammer home. It's a bit of an obsession for me. Sydney protocol biopsies, they're a headache, and I was always told by someone that I really trusted that, you know, if you find a part of your work really irritating, then just try and get a system together, try and audit it, you know, try and get an interest in it. Sydney protocol biopsies are painful. You get lots of biopsies. You know, the endoscopist is meant to biopsy from lesser curved body, greater curved body. This is the incisura, the junction between antrum and body, and then lesser and greater curve antrum as well. And I've actually created a Dragon data set just to remind myself for each biopsy to report these various different features. Just trying to stop some messages coming in here, sorry. So, and this, you know, is a very nice picture from Liz Montgomery showing the 2 antral biopsies, incisura, and 2 gastric body biopsies in a patient who has an unusual cause of her gastritis. And this is a gastrin stain, which you don't need, and I'll explain to you why, but it is helpful to show that you've got this line of gastrin expressing G cells here, which confirm that this one, and this one are antral biopsies, whereas these 2 body biopsies, although when you look at them here with long tortuous pits and short glands, you might think they're antral. This is because they're antralized body rather than true antral biopsy. So the diagnosis in this patient you can actually pretty much make at 0 or 0.1 times, and you don't need much of a higher power look except to look for the dysplasia in the cancer and any possible H. pylori. So anyone wants to pop that on the chat, the cause of this gastritis. The only thing I was going to say here is I often say not accessible for atrophy for the antral biopsies, because if you're looking for atrophy, what you're looking for is loss of the oxyntic cells. So obviously in the antrum you shouldn't get any oxyntic cells anyway, so I put atrophy not accessible for those. Obviously intestinal metaplasia is a surrogate marker for someone's written atrophic gastritis. Very good. I might need a little bit of help with that as to what type of atrophic gastritis it is and what the most likely cause is. So intestinal metaplasia is a surrogate marker for atrophy. So if you get something that's meant to be antrum or body and you get a lot of intestinal metaplasia, you can suggest that they also have atrophy, but it's easier to do in the gastric body when you lose your fillet. Well done, autoimmune gastritis, definitely. I'll go on to talk about that. So here is your typical demographic of a patient with autoimmune gastritis. So a 56-year-old female, she's probably got thyroid problems or some other autoimmune condition isn't uncommon. And the one thing which jumps out straight away is she's got a lot of intestinal metaplasia. Now, do we know whether this is body or antrum? It's tricky. It looks certainly antralized. But one thing I'll point out to you are these things here. 1, 2, 3, 4, 5. Once you get your eye in for these, does anyone know what they are before I move on to the next slide? I mean, it's the key to making the diagnosis. Here they are, these little round nodules at the base of the mucosa. The other thing to mention is in autoimmune gastritis, the inflammation tends to be bottom heavy. So unlike superficial chronic gastritis, like in that young lady with Helicobacter, the inflammation tends to be low down in the mucosa. These things, here's a bit higher power, possibly look a little bit neuroendocrine with this speckled cytoplasm, relatively monotonous round nuclei. This is ECL cell hyperplasia, so enterochromaffin-like hyperplasia. So these start off as linear hyperplasia, which you can't see without the aid of immunohistochemistry, but with ECL cell hyperplasia, nodular hyperplasia, that's something you can see on the H&E. So you can effectively make this diagnosis relatively easily on the H&E once you've got your eye in for it. So distribution matters. So autoimmune gastritis primarily affects the body and the fundus, and it has relative sparing of the antrum. So nodular ECL cell hyperplasia in true oxyntic mucosa is the crucial clue to making this diagnosis. So you need to confirm oxyntic gland loss, not just IM. So it is possible to make a false assumption of body mucosa if the site is mislabeled, and that's why it's important to have these Sydney protocol biopsies. I, for my sins, do a little bit of private reporting, and sometimes they're a bit lazy. They take lots and lots of biopsies, but they don't want any hassle, they just want the money. And I've had Sydney protocol biopsies all mixed up in the same container, complete waste of time. And I do write a bit of a sarky note on my report in cases like that. So, as I've said, gastrin is really useful. So there's 3 biopsies here from the same case. This is the antral biopsy. You can see this line of G cells here, which are gastrin positive, and they're absent in the 2 body biopsies. However, if you use a chromogranin you can effectively do the same thing. You can see the G cells because they're neuroendocrine cells. You can see that they label for chromogranin. But in the antralized body, you don't get a nice line of them because they're not G cells. They are ECL cell hyperplasia, so linear and micronodular hyperplasia. As soon as you see a few ECL cell nodules, you're pretty much home and dry with that diagnosis. So segue, I thought I'd use segues as a segue to talk about the link between atrophic gastritis, usually autoimmune, to ECL cell hyperplasia, and then neuroendocrine tumours. So this is how a smooth segue between ECL cell hyperplasia and how you can imagine how those nodules start to coalesce and eventually form tumours. This was actually, I'm making this company sound really bad, but I think because one of my local colleagues has made this misdiagnosis before as well. You know, it's possible in a grossly inflamed biopsy to be looking at and obsessing about this inflamed area and thinking, I better do a cytokeratin and make sure it's not carcinoma. And of course you do the cytokeratin and you see this slightly infiltrative looking proliferation in that area, and then you call it carcinoma. But if you look at the form, in fact the form was pretty obvious in this case because it said routine endoscopy for type 1 neuroendocrine tumours. You can see these beautiful little glistening polyps, look a little bit like fundus gland polyps, except they're reddened, eroded, and actually this mucosa is completely flat in the background. There's no folds in the gastric mucosa. So these are type 1 neuroendocrine tumours arising on the background of chronic atrophic gastritis. These are ECL cell nodules, which I've put a measurement on there. This is when I was using the gastric AI, which is actually really good at recognising neuroendocrine nodules as well. The RC paths say that ECL cell hyperplasia shouldn't exceed 500 microns in diameter. So if you see something which starts to coalesce, which looks like ECL cell nodules, and then exceeds 500 microns, so half a millimeter, then you can call it a neuroendocrine tumour rather than neuroendocrine hyperplasia. Personally, I'm a little bit more on the side of the American pathologist like Liz Montgomery, who says, well, if they biopsied a polyp, and I've seen a lot of neuroendocrine hyperplasia, then it's a neuroendocrine tumour. And I think that's quite a logical way of diagnosing these. But, you know, we play by the rules here in the UK a bit more. So these are the ones that I would point out. You're pretty much, even for me seeing almost every biopsy in the Southwest for many years, nearly all of them are these type 1s, okay? And Liz Montgomery will say they're not even worth grading because they're all well differentiated, they're all grade 1. And she's pretty much right. In fact, if you start doing Ki67s and mitotic counts, you'll occasionally find one or two which are grade 2. But they're generally incredibly indolent things, and you know, even for decades of surveillance, most of these patients don't develop any distant disease at all with type 1 neuroendocrine tumours. So they're driven by parietal cell destruction, as you know, autoimmune gastritis, and actually sometimes H. pylori can lead to destruction of the parietal cells, and then your antrum G cells will become a little bit excited, and they'll drive ECL cell hyperplasia to try and regrow this, regenerate this actinic mucosa, and instead you just get ECL cell hyperplasia and eventually grade 1 neuroendocrine tumours, and they turn to form little mushrooms in the dirt like this. All that happens on surveillance is they're looking for one that's got over the size of a centimetre, and then they should go to the specialist centre for endoscopic excision. So we've got a few patients at the moment with 8 or 9 millimetre diameter grade 1 type 1 nets who've been having regular surveillance, and they still grow by maybe 1 millimetre a year. Type 3 is the next most common, and in the books they say that they're always aggressive. In fact, with increased surveillance and increased endoscopy, I've seen a lot of type 3s which have behaved in a pretty indolent fashion and have been grade 1. But in type 3s, where I don't see this background atrophy, intestinal metaplasia, I always am very obsessive about grading these and counting Ki67s. Right. Oh, sorry. Type 2s, these are the ones that the medical students get excited by, which are driven by an exogenous source of gastrin, like a pancreatic or a duodenal gastrinoma. I've probably seen one in my life, and that was in a teaching setup. So this is a type 3 neuroendocrine tumour. You can see this beautiful normal gastric mucosa with the with all the gastric folds intact, definitely no atrophy. And then this, they actually thought this was a gist because it looks mostly submucosal. You know that neuroendocrine tumours are situated quite deep in the mucosa, so there's usually a bit of surface epithelium that's intact over the top, and obviously there's no atrophy, so they weren't thinking neuroendocrine tumour. But on the biopsy, this is a beautiful well differentiated grade 1 net with your synaptophysin and chromogranin staining and your normal oxyntic mucosa. In fact, perhaps some PPI changes here as well. Happy? I did make a note of this one because despite it being low grade and well differentiated, this had actually spread. So the patient had an octreotide scan and it had already spread to nodes, and they did end up having a gastrectomy, and it had multiple positive nodes, and I would suspect probably likely to have a liver met at some point as well. But we've had patients with well differentiated NET who've been going on for decades, even with metastasis, and they can be treated by the nuclear medicine radiologists. So these are true neoplasms, so they're not driven by the atrophy, they're not driven by hypergastrinemia. They have normal gastric pH, and they have normal gastrin levels. Okay, so this is going back to 2012. I sent this biopsy, or these biopsies. I think it was actually an EMR. Had an EMR of something which they thought was, a GIST or something, and it turned out to be an epithelial lesion. And I was just struck by how monotonous these epithelial cells were, perhaps a little bit serrated looking. Almost reminds me a little bit in the colon of something like a, traditional serrated adenoma, but this is foveolar adenoma. So this is a type 1 adenomas are, in the background of intestinal metaplasia, they look like colorectal adenomas, and you do get those in the stomach. But type 2s are either foveolar, pyloric type, or oxyntic type, and this is the most common, foveolar adenoma. Again, this dysplasia is very difficult. On a tiny biopsy, I think this patient had 5 or 6 preceding biopsies which were all reported as normal or reactive gastropathy, and of course that's because it was foveolar dysplasia but just wasn't diagnosed. But this thing was 5 or 6 centimeters across, so obviously they didn't believe us and they took it out. So often small, sessile, polypoid lesion, usually H. pylori negative, but can be seen in autoimmune gastritis. So it's all about the low power architectural assessment. These glands are crowded, they're obviously very elongated. The other thing that I did think about in this patient, and I asked Neil, was, has this patient got a syndrome? Have they got some sort of ectodermal abnormality or endodermal abnormality that's driving this? But it was a sporadic foveolar adenoma. And this can help if you're into immunohistochemistry. If you do MUC5 on normal gastric mucosa, it will only stain the foveolar pits. So if you do a MUC5 on a foveolar adenoma, it will stain uniformly all of the epithelium, generally. It's not brilliant, but it can be good, and this one worked. What I find just as nice, actually, just to confirm foveolar dysplasia, foveolar differentiation, is this preserved PAS-positive mucin cap, which you don't get in the other type, which I'm about to show you. I'm about to show you after this one. So this is the only oxyntic gland adenoma which I've ever seen, and it was as a second opinion case. So the dysplasia, rather than being in the surface foveolar epithelium, occurs in the oxyntic glands itself. Very difficult to diagnose, very rare. Some people don't even believe that these exist. And that's from a website, because I couldn't find a good picture. So this is a case which I had about a year ago from an elderly patient. Oops. And it was a big polyp. So it was, I think, 3 or 4 centimeters diameter. So obviously it was a significant lesion, and histologically it showed obvious dysplasia. In fact, my question for sending this to some colleagues up country was, do you think this is high grade? And I think we all, on consensus, thought it was just about high grade. The Americans grade these quite highly. I think half of people I sent digital images to thought this was still low grade. Unlike foveolar dysplasia, this is actually MUC6 positive, and MUC5 in the dysplastic area was negative, and you also lacked that apical mucin cap, which you got in the foveolar adenoma. So this was the area which I thought was just about high grade. So these polyps carry substantial risk of associated or subsequent adenocarcinoma. You can get these in FAP as well, and also Lynch syndrome. This is a case which I diagnosed which didn't have any dysplasia. I didn't have any proper dysplasia. Sometimes they talk about the foveolar cells as having a ground glass cytoplasm. I'm not sure I can really appreciate that. But the key to this was it was a 6 centimeter lesion, and the patient had FAP. So it's an uncomfortable concept, really, isn't it? Adenoma without dysplasia, but it can occur. So this is a beer that I tried in California, and it reminded me of signet ring cancer and other things. So I'm talking about sneaky devils. So this is we sometimes get these biopsies that are just so inflamed that we start to be concerned that something else is going on. So this is a red area in the gastric fundus, clinically gastritis, and I was a bit concerned about these pale cells which were infiltrating the gastric glands. Otherwise, this infiltrate looks quite mixed, doesn't it? There's some lymphocytes there, some plasma cells. It's not full of blasts. It doesn't look like a high-grade lymphoma. But what's this? This is a gland which has virtually been destroyed by these pale, abnormal, slightly irregular-looking lymphoid cells. This is a lymphoepithelial lesion. And if you do a CD20, you'll see that it's almost black, isn't it? There's so many CD20 positive cells outnumbering your CD3 and CD5. So this is a low-grade B-cell non-Hodgkin lymphoma of marginal zone type, which we call MALT lymphoma in the stomach. So H. pylori drives the development of MALT, which is mucosal associated lymphoid tissue, and that can become neoplastic. And I put neoplastic in inverted commas because it's a kind of in the hinterland between neoplasia and reactive, because one thing that's unusual about MALT lymphomas is they nearly always, if they're limited to the mucosa and submucosa, they resolve with H. pylori eradication. In fact, the BSG tells us that even if we can't find H. pylori, I have to remind my clinical colleagues sometimes, even if we don't find H. pylori, they still have to eradicate it and give them eradication therapy in MALT lymphoma. And the unusual thing about this particular case, which I diagnosed, is when I looked for the H. pylori, this is one time where I did have a Giemsa. These are unusual looking organisms. I don't know if anyone's seen these, but these spiral shaped organisms, which you can see here, much bigger than typical H. pylori. So this is Helicobacter heilmanni, which accounts for a very small minority of gastric MALT lymphomas. So most are H. pylori positive. I think 60 to 90% are H. pylori positive, and actually most of the remainder H. pylori is never found, but eradication does still cure them, or at least put them into remission. So Hillmanni, I never know quite how to pronounce it, are pretty rare, and sometimes linked to dogs and cats, and sometimes people that live on farms and things like that. It's a zoonotic organism, but in this particular case, I was able to find it in the context of a malt lymphoma. This is a chance to plug one of my retired colleagues' papers, and I call this, he has solitary epithelial cells, which I think is SECS, S-E-C-S. So you get solitary epithelial cells when H. pylori leads to florid lymphoepithelial lesions and epithelial destruction. So if you do an immunohistochemistry for a cytokeratin in malt lymphoma, not only is it useful for identifying the lymphoepithelial lesions, here you can see the holes made by the lymphoid cells, is that you get these surviving single cells. And interestingly, these stain for neuroendocrine markers as well as epithelial markers. So chromogranin in this study by Mark Smith and Judith Sutat. This is just something that you should know about when you're doing your exams. I can't remember any of this, but there is a Witherspoon and Peter Isaacson paper talking about the features of malt lymphoma. And you get a lot of these suspicious biopsies, where they're not quite diagnostic. The key, I find, to diagnosing malt lymphoma is the presence of centrocyte-like monocytoid B cells. Okay, so they're ones with clear cytoplasm. You get your eye in for them, you can identify these. And lymphoepithelial lesions. So everyone, every pathologist is slightly between these two, I think. You give them to different experts, then someone will call it a 4, someone will call it a 5. It's not like other lymphomas where if you think, oh, I don't want to overdiagnose it because they give them chemo. With malt lymphoma, they tend to just give them H. pylori eradication, so it's not particularly, a scary consequence of your diagnosis. So this is a slide from Jason Hornick from a resection specimen that obviously had a resection specimen for something else, presumably. And this is a malt lymphoma, just showing how, again, it's a bottom-heavy infiltrate, often with lymphoid follicles as well. Remember, marginal zone lymphomas often leave reactive germinal centres around as well, and you can see it's very deep, spreading right down into the deep submucosa. And these are the lymphoepithelial lesions, and you can see these very nice, clear monocytoid B cells. I just put this line in my opinion, I don't think there's a lot of help for immunohistochemistry other than to confirm that they are B cells rather than T cells or non-lymphoid cells. Of course, one of the concerning features is, are you missing a carcinoma, which can have this diffuse appearance occasionally. And I don't do clinality personally. I would certainly not recommend doing clinality studies on something which is, unless it's completely barn door. If you've got a barn door malt lymphoma and you know that they're going to be treated with H. pylori eradication, it may be worthwhile, because when they recur, if you've identified a molecular abnormality and then you can show if the patient recurs they've got the same abnormality, or when it goes high grade, then you can help guide the treatment, further treatment. But otherwise, not much help. This is a bit of a pitfall in malt lymphoma, and in fact this is from a case, or certainly a case that's like one that I've misdiagnosed myself. So this is actually a diffuse large B-cell lymphoma with a sort of slightly monocytoid appearance. So it's worth doing a Ki-67 just to make sure it is certainly a low-grade lymphoma rather than a diffuse large B, which obviously would have a different treatment and won't respond to H. pylori eradication. This was a diffuse large B-cell lymphoma. This is from Jason Hornick, showing a really prominent clear cell appearance. And I think in this kind of case, personally, I'd want to do a cytokeratin as well, just to make sure it's not carcinoma. I'm getting a bit of a dry mouth. Do you mind if I just have a very quick glass of water? I'll be right back. Right, sorry about that. So, another sneaky devil. This is a case which I presented at an AI conference, which I initially, well, I used the AI just to see how good it was, really, to find this one which I'd called suspicious of low-grade multiple lymphoma. So I'd already worked this case up. I had these biopsies. It's from an elderly lady with this nodular friable area in the gastric fundus, and there was a little bit more to it than met the eye. So it's got beautiful monocytoid B-cell hyperplasia. It didn't look high grade, it looks mixed. There was some lymphoepithelial lesions, a bit of epithelial destruction, and I'd called it suspicious of multiple lymphoma. And what was nice is I had a Helicobacter immunohistochemistry, which was nicely positive as well. Beautiful morphology. But when I started to do immunohistochemistry, yes, they're all B cells, but I did this cytokeratin, and just before I signed it out, I just spotted this slightly irregular area of cytokeratin positivity, and I thought, well, maybe it's just a lymphoepithelial lesion. But when I zoomed in, I found on the 6th level this tiny area of intestinal type adenocarcinoma. So this was adenocarcinoma plus multiple lymphoma. And this was a tough Cornish lady. She had her H. pylori eradication, and they rescoped, and hey presto, on the rescope they found an obvious tumour, which was an intestinal type adenocarcinoma. She actually made it through neoadjuvant chemotherapy and had an operation, and she had a T1B adenocarcinoma with no nodal involvement and no evidence of residual H. pylori gastritis, and to my knowledge she's still doing well. So the malt had gone. So actually getting rid of the malt lymphoma made the endoscopy much easier to interpret, and they found the tumour. I just thought I'd talk at this point about the Loring classification. So this is a professor from Finland. In 1965, it's still the classification which the clinicians like the best, and I must admit I do as well, although it's pretty subjective. So Pekka Loren diagnosed two separate sort of extremes of types of adenocarcinoma in the stomach. One which he called intestinal type, which pretty much looks like colorectal adenocarcinoma. It's either tubular or papillary, and often has these irregular glandular structures with, dirty necrosis and that kind of thing. Or you've got this diffuse type adenocarcinoma, which classically has these mucin-filled signet ring cells, but not always. And this is a resection specimen from an intestinal type adenocarcinoma, showing a sort of classical junctional location, the esophagus here and the stomach, an obvious tumour that the surgeon can find and resect and identify and stage. In contrast, the signet ring cell, or the diffuse type adenocarcinoma, is more of a pale sort of, this is a leather bottle stomach, so a linitis plastica. Here, this is the lesser curve and the greater curve, and this tumour spreads all the way from up here next to the spleen, down through here. This is the incisura, which is the highest risk area for adenocarcinoma, and it's very hard for the surgeon to even find where the tumour starts and stops, and also similar for the difficult for the pathologist as well. And the WHO classification later on changed intestinal type to different morphological types like tubular and papillary adenocarcinoma, and the diffuse type called poorly cohesive carcinoma. The reason for this is that not all diffuse type adenocarcinomas are made up of signet ring cells. Sometimes the cells almost look fibroblast-like, but or don't have classical signet ring cell morphology. They can look, for example, plasmacytoid or a bit like lobular carcinoma. This was a classic biopsy for a signet ring cell adenocarcinoma in a patient who had linitis plastica, and actually it was the third time that they had an attempt to try and get this diagnosis, and this time took 20 biopsies and one area. 12 biopsies, I think it was 20 millimeters squared. There was one 1 millimeter diameter area which had these signet ring cells. Classically, we don't reflex test adenocarcinomas, but obviously if the patient is fit to either have chemo or radical treatment, then we do, and we do MMR, IHC, and HER2, and PD-L1. And I've still not seen a single true signet ring cell adenocarcinoma, with no cohesion at all, which is HER2 positive. So if you're getting a HER2 positive, don't think you should really think carefully about whether it's a true signet ring cell or whether it's cohesive. This is the difficulty with calling something signet ring cell adenocarcinoma, is sometimes you get these ones that don't have mucin at all. They just look more like plasma cells. In these you need a cytokeratin to make sure that these odd cells are definitely epithelial rather than, lymphoid even, or melanoma, or some other differentiation. Usually you see around, you'll be able to find some more classic signet ring cells, and sometimes the tumour cells can almost look like fibroblasts or be very difficult to identify as epithelial at all, but these would be called poorly cohesive adenocarcinomas rather than signet ring cell. So I personally would use a broad spectrum cytokeratin, something like AE1/3 or MNF116, rather than a mucin stain, because you'll end up missing some of them if you just use a mucin stain. And I tend to have quite a low threshold to do this. Sometimes I'll have these biopsies and I would have seen the CT scan myself and it's a classic linitis. It's going to be there, but it just may not be there in the first set of biopsies. And usually, or sometimes, the patient needs to go to the specialist centre and have what's called bite-on-bite biopsies, which is where they take a bite into what they feel is tumour, and then they have to go into that hole again and take another bite. There's a very high failure rate of getting diagnostic biopsies on this kind of thing. And there's this quote which I'm sure you might have heard of, that there are two types of pathologists in the world: those who've missed a signet ring cell carcinoma and those who will, or those that have missed one, or those who are liars. This is just some other subtypes which I think are important to know about. This is the gastric carcinoma with lymphoid stroma, which, sometimes lymphocyte rich, we used to call it, gastric cancer. And the archetypal, one is the EBV positive, so this is EBV-ish. These have nests or fused glands. They can either be a sort of intestinal type pattern or a diffuse type pattern. They're more likely to be the cohesive pattern, and they have either they're EBV positive or they have another abnormality, which I'll move on to. The importance for recognizing these is, A, they respond really well to almost any treatment. They do very well for stage, and they are very commonly PD-L1 overexpressing, so they respond to immunotherapy. This is one which I had last year, which a colleague brought to me, and I immediately said this is lymphocyte-rich gastric cancer. EBV was negative, so what do you do if the EBV is negative in a lymphocyte-rich gastric cancer? You do MMR-IHC, and This was MLH1 and PMS2 deficient. So MSI high or MMR deficient gastric cancers are almost invariably sporadic. However, if this was in a younger patient, I'd obviously consider Lynch syndrome. You can't just do a BRAF stain like you can in colorectal cancer because the sporadic ones don't have BRAF mutations. So you need to send these away for MLH1 methylation testing, which they almost invariably are hypermethylated. But that's something you can do at a later stage. There's no rush to do that in an elderly patient, but it is obviously important. You will occasionally get Lynch syndrome patients diagnosed this way. This is something which I became aware of, interestingly. You go to a conference, I saw Fatima Carniero talking about enteroblastic adenocarcinoma, hadn't heard about it before. It used to be called hepatoid carcinoma. You know, sometimes they can look really like liver, but more often they look like this fetal liver or almost endometrioid appearance with like these Schiller-Duval body kind of things. And so I saw Fatima talk about this entity, and then literally the next week I picked up a biopsy and I was like, oh, it's enteroblastic adenocarcinoma. I'm pretty confident on the H&E, but I did the extra testing. The AFP was positive, the glypican-3 was positive, and that made the diagnosis. So what's interesting about this, I think if you called it poorly differentiated adenocarcinoma or intestinal type adenocarcinoma, it wouldn't be disastrous, you know, but I think that usually CDX2 positive as well, so there wouldn't be anything that would immediately stand out as being a different type of carcinoma unless you did some extra staining for AFP and glypican-3, for example. If they do recur, you can sometimes do an AFP serum marker and check for recurrence. So imposters, just a few funny cases to finish off with. 3:15. Are we okay for time? So I have seen probably now quite a lot of imposters in the stomach. What do I mean by that? This is a lady, 72-year-old female, the classic history with a diffuse type adenocarcinoma is they have gastric outlet obstruction. And then they have a CT scan and you get this enhancing thick-walled appearance of the stomach. And it's nearly always poorly cohesive adenocarcinoma. So if you get a biopsy like this, and you just call it poorly cohesive adenocarcinoma, you'll be right 99% of the time without doing any immunohistochemistry. In this lady, I decided to do some immunohistochemistry. Most of these were signet ring-like, but some of them were just a bit different. So E-cadherin negative, that's pretty common for just a gastric poorly cohesive carcinoma. But this was also GATA3 positive, ER positive. And this woman not only had linitis, but she also had a new breast mass, which was lobular carcinoma. So she didn't even have a history. But most of the time, these patients, and I would say I've probably seen 10 of these now, I would say, and I think 9 of them had a history of lobular carcinoma, sometimes from a very long time ago. It can be from so long ago that the clinician has no idea. You know, they don't know. It might not even be on your limbs, it might be on another limbs from another hospital. So it's always be aware of that in a female, particularly a female of reproductive age, that she might have metastatic lobular carcinoma. And it can look clinically just like diffuse gastric cancer, but it's a disaster if they have a gastrectomy. These can just be treated with hormones and chemo. This was another one which clinically looked a bit like linitis plastica, so a leather bottle stomach on the CT, but it was an 80-year-old man, and he also had an ulcer in his lesser curve, which was biopsied. And you know, there was something about these cells that didn't look quite right, quite prominent nucleoli, but you know, possibly some vacuolated cells that might be signet ring cells. Cytokeratin was negative, still might be a carcinoma, but this was melon A, SOX10, S100 positive. And this patient had a melanoma on his finger, that he had an amputation for 2 years previously and had an axillary node which was thought to be intracapsular nevus, but obviously was melanoma. I've now seen melanoma in the stomach a good 5 or 6 times. And most recently, I think this was pretty recently actually, certainly in the last year, it was quite a small polyp here in the stomach, which is, you know, had this little area of induration in the centre and perhaps was a bit brown looking. And I got the biopsy literally on the way to the MDT. And so I hadn't had the chance to write the report or anything, but I looked at it and I saw these prominent nucleoli and I saw this pigment around and I thought, this is melanoma. And I went to the MDT and they looked at the scan. Unfortunately, he was riddled. He had liver mets as well. And they said, he's too elderly and too frail to have any chemo, so we don't need any testing. And I said, what about if it's melanoma? And they said, oh, we'll definitely want it then. So I did, so I thought it was melanoma on the H&E, and it was confirmed to be. And it did have a BRAF mutation, and so this patient was able to go on to tablet medicines for the BRAF inhibitor. And, you know, this can keep people alive for a long time. It was SOX10 and melanoma positive. Right, I think we're almost at the end. I wasn't sure if we'd have time or not, but I've just got this case that was, I thought it was a bit, I didn't think it was a great case, but for some reason the IBEX people, when I did the AI study, they just loved it, and other people find it interesting as well. So this is a patient in her late 60s, and again she had this linitis appearance. Here's the antrum here, and she's got this thick-walled enhancing mass obstructing her stomach. And I don't know what, I went completely insane on this biopsy. I did 12 levels on it because I kept seeing this area in the middle of the biopsy that just looked like lymphangitis, but I couldn't see any tumour cells in it, but the vessels looked abnormal. I knew the patient had cancer, and they'd done really good biopsy, so I thought, well, I've got to give it the benefit of the doubt, I'll just keep cutting. And on levels 11 and 12, I found this little area of blobs of fibrin here, and I think eventually on the 12th level, I found a few tumour cells in it. And the IBEX algorithm spotted the cancer even before I could see it morphologically. 0.2 millimetre focus of cells that were only in a lymphatic. So that was the tumour cells there, which the IBEX algorithm found in a lymphatic, and these were TTF1 positive. And actually it turned out when the patient had a full staging CT that she had a lesion which initially the radiologist thought might be a metastasis. It turned out to be a spiculate primary cancer, so she was able to go on to the sort of lung type chemo. So that was a wild one. So I've seen hundreds might be an exaggeration, maybe 20 metastatic cancers to the stomach now. I don't think I've seen any to the esophagus. It's very rare. You occasionally see extrinsic invasion, but you don't see metastases to the stomach. But for some reason, sorry, to the esophagus, but the stomach is a really good place for cancers to metastasize. So what do I want you to remember from my talk? Well, hopefully you've been awake during it. I've had a few messages come in. Sight matters, right? So the body and the antrum is important to be able to distinguish. You don't want to misdiagnose body versus antrum versus antralized sight, as you might misdiagnose the pathology. Pattern beats cells, okay? So always assess the architecture in the background before obsessing about individual cells. We all obsess about individual cells, but just take a step back. Reactive changes can look awful. We've all heard of stories where, you know, someone's had some NSAIDs and then someone's called it cancer because it looks really atypical, but it's just reactive change. And pill gastropathy can look awful. It can look awful clinically as well. So the worrying thing I always think about pill gastropathy is if you call it cancer or dysplasia, you quite often can convince someone that they've got cancer. And the CT sometimes, you know, in T2s and early T3s is not very specific for cancer. Bland does not mean benign. So gastric type adenoma, I showed you the foveolar adenoma, very monotonous. In fact, it's the monotony that gives the diagnosis away. It's not pleomorphism like you get in the sort of genomically unstable cancers. And then pure signet ring cell carcinoma actually can be incredibly bland. You can get these little balloon cells with very small nuclei just dotted throughout the mucosa. You always need the context and cytokeratin stain in cases like that. So signet ring-like cells are common. I've actually not shown you a lot of artifacts you can get in ischemia, for example. You can get very, very ischemic-looking, very signet ring-like cells. So use cytokeratin wisely. Don't reach for, don't do CD68. It's a complete waste of time. Do your cytokeratin. It'll get you the answer. Negative biopsies don't always exclude disease. So Linitis, sometimes second or third lot of biopsies. People really worry about missing one signet ring cell. The bottom line is no one's going to be able to give treatment or a radical treatment on one or two signet ring cells. So if you miss them, it's not going to matter. The clinician will be chasing it and wants another biopsy. So there's nothing wrong with saying suspicious, for example, or not diagnostic. And more than one thing might be going on. This is something why I obsess about these Sydney protocol biopsies. I do them on a proforma because I want to be systematic. I don't want to miss the IM. I don't want to miss the atrophy. You will not, here's a golden rule, you won't get Sydney protocol biopsies. If you go through them and you think they're normal, you've missed something. There'll always be something on Sydney protocol biopsies. Final thing, fear is healthy. There's nothing wrong with being afraid. I think fear drives a lot of us in our work. But there's no problem with saying that something's non-diagnostic or indefinite. It's a valid conclusion. Clinicians just want an action plan. If you say, I need another biopsy, no one's going to complain. So gastric biopsies are subjective, they're humbling, and the stakes are high. We can be afraid of missing something. No one wants a negative gastrectomy on return of post. So if you're uneasy, pause, review at low power, ask for help, use your colleagues. This is lucky. I'm lucky to have this in my front yard. That's 100 metres from my house. So come and work in Cornwall. Any questions?
There's a couple of questions in chat, Tim, from Phil.
Yes, I see it. Okay.
Yeah.
Shall I read them out? Is that all right? So.
Yeah.
Did the AI spot the signet rings with the malt lymphoma case? Yes, it did. The AI, I've got to say, was, I don't know if I did say, I'll probably put it in my introduction. There is a video of me on YouTube with all the cases that I gave. Well, actually, not all the cases. I gave it probably 100 or so really difficult cases. It didn't miss a single cancer cell. The problem with AI, well, there's lots of problems with it. It's incredibly expensive. It'll cost you as much as a colleague. All it does is say, this is suspicious, which we can do anyway. It doesn't do any of the work for you. It might say this is cancer, but you've still then got to subtype it most of the time. I mean, it'll obviously get there.
Sounds like a training to me.
Well, exactly, but it is incredibly impressive, and it will not. And one of the things that I liked best about using the AI is it teaches you as well. So, I talked about ECL cell hyperplasia. Well, there's a neuroendocrine module on IBEX. So what I started, in fact, we worked on it a little bit when I was working with IBEX, because I was able to identify linear and micronodular hyperplasia on an H&E with the IBEX algorithm. It's fantastic. But you still got to do the work.
And that's where it differs.
But I think for something like Sydney protocol biopsies, it was brilliant. It was a really useful thing. But you want it to write your reports. I think the sort of Copilot and ChatGPT formatting your reports and identifying problems is probably more useful than the image recognition things. Right, Philip, do you ask anything else? Would you do a PDL1 in a gastric adenocarcinoma if MSI? No. So we've, having said that, okay, what we do now, what we used to have was an algorithm whereby you do one and then you find an abnormality, then you stop. For example, HER2 is the most common. So intestinal type adenocarcinoma, I've got my eye in for it now, and I'll tell the oncologist this is going to be HER2 3+, and most of the time I'm right. So if you find a HER2 3+, that's it. They go on to treat them. They've changed the algorithm slightly recently, and you just start off and you just do MMR in our case rather than MSI. Keeps your eye in. HER2 and PD-L1, so you do all three. I've had, a handful of MMR deficient ones recently, and actually they're nearly always PD-L1 high as well, because most of them are the lymphocyte rich subtype. What I'd be interested to find is, you get the other subtypes like the mucinous one, that sort of heterogeneous mucinous but quite monotonous nuclei. I don't know if those would be PD-L1 positive, but it's a good question. But at the moment we're just throwing it all at it. I think the future is going to be, for AI, for example, be that AI will help you identify and triage to the correct molecular test. Because at the moment what the oncologists are doing, they're saying do everything on everyone. Complete waste of time. In fact, in Cornwall, I've stopped them doing this reflex testing because 2/3 of our patients are straight to palliative care. So that's an awful lot of money and staff time you're wasting if the patients are all just either having a stent put in, or just palliative. You can always do, so I sit there and I go, okay, patient's fit, they've got metastatic disease. The other thing is localized disease and they're fit, they go to surgery, then you've got a better specimen to do your molecular testing on. Does that make sense?
That's interesting, thanks. I've seen talks on AI, like with the lymphocytes identifying likely MMR deficient tumours as well. So on morphology, saving time to a degree.
Yeah. I mean, I think, I like learning these patterns. There's definitely. I remember David Poller saying to me that he can recognise BRAF mutated thyroid papillary carcinoma as well. I mean, it's like the tool cell variant and things like that. It's quite interesting to keep, rather than just sort of getting your molecular test back and just sort of authorised, don't look at it. Have a look at the case again, because I swear, if the AI can recognise it, we can recognise it as well. There are some very obscure patterns that the AI is able to recognise that we're going to struggle to recognise. But, I didn't believe that I could recognise ECL cell nodules. I recognise them on H&E now all the time. You can definitely learn this. And AI can help us be better. I think most people are worried about the AI just putting us out of a job. I think we should be looking at AI just making us better at what we do, and actually moving away from the sort of fishing expedition of just doing every molecular test on everyone, and going to the point where we go, giving the oncologist defined parameters, which will give a particular risk or guide the clinician into giving the right chemo. I think that's the future.